So first off, I'm Chris Martingill. I'm the president of Prehospital Guidelines Consortium, and I'm very glad to have with us Dr. Panchal, Dr. Sasson here that I'll be introducing in a minute from the American Heart Association, and also wearing dual roles as they are both intimately involved with the Prehospital Guidelines Consortium. The goal of what we're going to try to do today is talk about the implementation and dissemination of guidelines using essentially a textbook example of American Heart Association's tremendous efforts, now informed with the substantial effort that just happened in 2025 with the dissemination implementation of a huge new guideline update, which is great, and we have a lot of opportunity to learn from that and to translate some of that knowledge to other guideline developers. And we will have credit available for this. I see that conversations around that are going on in the chat, so please follow along with that. But for those folks that are joining, we will have the opportunity for credit for those engaging live through the AME or CAPC credit. Now, want to give an opportunity for folks to introduce themselves actually much better than I can do. So Dr. Sasson, if you wanted to just say a quick few words about yourself.
Great. Thanks again, Christian, for having me here today. So I am here on behalf of the American Heart Association. In that role, I've been able to be very fortunate to work with Ash and 150 plus volunteers from the Heart Association to write the new CPR guidelines that were released on October 22nd. I also work with our ILCOR group, which is our International Liaison Committee on Resuscitation, which is another 200 plus volunteers. So when we talk today about the guidelines, I want to make sure we recognize the tremendous global effort that has gone into putting these guidelines together. And then, of course, with the Heart Association, we've been very fortunate to also release our training products on the same day as the guidelines, which was new for us and a big feat. So we'll talk a little bit more about that as well. But thanks for the opportunity to be here. And I'm an emergency medicine physician, addiction medicine physician as well, and then do health services research on the side and opioid safety.
Very good. Lots of hats, plenty of hats. That is a theme here. And Dr. Panchal?
Hey, everybody. Thanks for having me. This is fantastic. My name is Ash Panchal. I'm a professor of emergency medicine at The Ohio State University. I was also chair of I still am actually, a chair of the American Heart Association's Emergency Cardiovascular Care Committee. In the last guideline process, I've been involved in multiple roles throughout the guideline process, including chair for the science subcommittee as we developed the original 2025 guidelines. I've been involved in guideline development for the American Heart Association since 2015, 2014, around there, so a couple years. In my day job, I'm a pre-hospital researcher, so about 80% of my life is all about pre-hospital care. I'm a medical director of an EMS agency. I'm also research and fellowship director for the National Registry of EMT, which is a national certifying body for EMS. So lots of different things, but at heart, I'm an educator, so it's great to be here and it's great to talk about this.
All right, and I'm Chris Martingill. I'm an emergency and EMS physician in Pittsburgh, and as I mentioned, the president of the Prehospital Guidelines Consortium with quite an interest in helping to support and learn from our partner organizations as it relates to the development, dissemination, implementation of guidelines. So that is essentially much of what we're going to talk about today. So let's talk about timing of guideline updates. So one of the things that has come up in the review of guidelines across a variety of developers is this concept of, we get a guideline, it's developed, we publish that guideline, it's out there for the world. Hopefully it's actually getting implemented and used by individuals out there. But at some point, we know that the science changes. And so we need to get an update for a guideline to occur. And it turns out that there's some entities that are very proactive and thoughtful in terms of how we're going to update those guidelines and try to come up with a schedule for that to happen, a process for that to happen. And having, for the PGC, reviewed what we would say most pre-hospital guidelines that are out there, systematically, we realize that many guideline developers publish a guideline. It's a great worthy effort, but there's no real plan for when that guideline is going to be updated and not a real mechanism for that to happen. And there are many potential barriers for that. But I'd like to start the conversation here. Ash, if I could put you on the spot a little bit here, And can you talk to me about some of the things that folks should have in mind in terms of, why we would want to update a guideline in a certain period of time, or some of the, some of the challenges that folks experience there?
Well, I think fundamentally, when we think about guideline development processes or any type of process where we're providing recommendations, the fundamental concept is that we want this to be updated with the most recent data so that we're not talking about something which is 5 to 10 years old, right? Like if we think about how quickly and exponentially science is developing on a daily basis, this is a huge challenge across the board. Like we could put down a guideline around cardiac arrest, and in the next year, we could have 3 randomized controlled trials on the same question coming out. And this is not just special to cardiac arrest. When we think of pre-hospital care in general, like we have some experts in the room regarding seizures, Manisha's here, and others who are doing amazing work. And the fact of the matter is the timeliness of this work and how quickly it comes out, we're going to need to keep updating those recommendations in a timely manner so we know what the best thing we can do for our patients are. And if we're not attentive to that, we actually put people at risk. And so there is that really strong balance between really giving a high quality guideline and making sure that it stays relevant over time. And how do we find that timing? And a lot of guidelines, we don't really have that.
Yeah. And, it's interesting as I think about the ways that we assess the quality of guidelines. There's a variety of criteria out there. The PGC has done systematic reviews of the quality of guidelines. And we look at, for example, the agreed to scoring. And one of the items as part of that scoring is to include within a guideline a plan for guideline updates and some concrete idea. And as we evaluate what guideline writers create and the published guidelines out there, that ends up being missing from a lot of guidelines. And that may be because a guideline gets written as a specific funding effort. So you have some grant, there's a topic, there's a need to write a guideline, there's a project team that gets funded to provide that effort, that guideline gets created. And it's not like that grant's going to exist in perpetuity. So there isn't necessarily a concrete thing for when we have, because otherwise, obviously, we would want to update and have a plan to do that. But other considerations I'd have, and we're going to get into the American Heart Association's kind of cycle for guideline updates, and with a focus on 2025, because I think that there's a lot for others to learn from there. But Camilla, could you talk to us a little bit about kind of big picture? What are some of the things that go into that update in terms of considerations for dissemination, all of the stakeholders or partners you might think about, some of the barriers to kind of getting the next version out there?
Thanks, Chris. Great question. So just to kind of dovetail on what Ash was saying, we are very fortunate in that we write guidelines, and we have continuously written guidelines for decades. And so what we've done is we put a process in place in which our emergency cardiovascular care science subcommittee actually oversees the writing groups. And those writing groups are at the ready, right? So they are people who are already identified in different topics like ALS, PALS, et cetera. And so when, let's say, a landmark study comes out, let's say an RCT that comes out on, for example, temperature control for cardiac arrest, we have that writing group ready to go. And that writing group basically there has to be some criteria that must be met, which is we don't want to be changing recommendations just based on one RCT oftentimes, right? We want to make sure that the amount of evidence is sufficient enough to actually be able to change or even, further promote the recommendation, right? So sometimes we don't change the recommendation. We actually say this recommendation is correct in the context of this new science that has been published. So there has to be that first question, which is there enough data to require an update to the recommendations? The second is when the writing group looks at it, they may or may not choose to say that there is, right? So there's always that sort of interplay. And then the third thing is we actually do a cycle of focused updates. So as you may know, we've been doing that 5-year guideline revision where we completely rewrite the guidelines over a 5-year cycle. Again, that's been something that we've done for many years. But we do put in that interim, we had released an advanced life support focused update, a neonatal focused update, a topical one on drowning, specifically because we knew that this was a topic that was not well covered in our 2020 CPR guidelines. We did an entire focused update on toxicology as well. And so we have that ability, I think, really to be able to sort of say, these are topics that we think are important, contemporaneous, and we have the volunteers who think that there's enough science there to change it. Now, that also then has to translate back into what do we do if there is, let's say, a guideline change or recommendation change. So, for example, for temperature control, we had recommendations that were integrated into advanced cardiac life support, which is our major dissemination tool for getting out recommendations from our writing groups on how to care for patients with cardiac arrest. And so what we had to do then, and as the writing group was writing that, was look through our content in our products and be ready on the ready so that when that focused update comes out, that we can say, look, all of our instructors, this is a big change that's happening here. All of our online materials, these are the changes that are happening. And so we actually have a plan in place in which our product teams are basically working hand in hand with us to make sure that our stakeholders, which are our instructors, our end users, which are our healthcare professionals, and then, of course, all of the hospital healthcare systems as well are aware that there's a focused update coming out and that we are going to have a change in, let's say, the product itself. And then from there, we want to make sure that we have the right folks, available when questions arise, and then having all the right materials that can be ready to go on the date of release. So that's just sort of a way in which we work on the focused updates, but even that translates out to our CPR guidelines as well.
That's a whole lot of things to try to get in line. A lot of partners and a lot of entities to really get to row in the same direction and make one of these updates happen. And to kind of put more concrete things here for the AHA's perspective, Asha, I was hoping that you could walk us through a little bit of this update cycle that has just happened with the 2025 guideline updates. We saw these come out, big splash coming to us from Europe in collaboration with other entities. And now in North America, we have the AHA guidelines that took a whole lot of effort. Could you talk to us a little bit about what went into that specific project over this time period?
Sure. I think one of the biggest things that really struck me, because I was chair of BLS and ACLS for the 2020 guidelines, so I was the first author. And even though I was critical in that first 2020 comprehensive update, when you're starting with the next cycle and you look at the whole span of what you got to do to get to the end point, it's pretty amazing the pathway that you have to follow to get there, right? Because let's be honest, after you do something that big, people are tired and you need a little bit of time to recuperate after something that big. So you can even see, this is our 2025 ECC CPR guidelines timeline. And we started putting our writing groups together back in 22. So where we're starting to actually start to having discussions that, okay, we did a great job in 20. We got lots of feedback. We got webinars, podcasts, lots of complaints and discussions. And that's what we want. We want those robust discussions to happen. And that leads us to start thinking about, okay, what's these next topics? What's the next gaps we need to close? And we start thinking about what these topics are, and the research and pulling all this stuff in begins back in that time period. And so in July of 22, we started actually having these discussions. And we started putting together writing groups to start talking about what's cool and interesting in ACLS. So this time I was on ACLS, and it was a huge discussion because at the same time, I was also first author for chapter 2, which is our evidence update. How do we do the methods for all of this? So we have this connection between improving our methods and working with our writing groups to get to the point that we're starting to put data together. And from July 22 to June 2024, a 2-year time period, we were evaluating gaps. We're working with our ILCOR partners across the world to really start talking about what are the systematic reviews we need to do? What's the evaluations that need to happen so that we can answer these big, difficult questions? And then in June of 2024 is when we really started saying, okay, let's start drafting what these basic ideas up to this point we have. And so we go back and we even started going back and looking at those original sites and saying, hey, let's just do one more cleanup. Let's do one more search to make sure we didn't miss anything. So you can imagine the amount of work that these volunteers are doing to get us to that point where we could actually start reviewing and really copy editing it down to the point that we start getting an idea. The copy edit was actually in February of 25. And then from there on, we're in our peer review cycle. And our cycle of reviews all the way from March to July, where every single piece is touched and everyone's talking about all the content that we put together, because let's be honest, we have 150 odd people, scientists, who are putting these concepts together, and we want that feedback. We want people to push back so we understand what's right, what's not right. And it gets us all to the point that we produce in August of 25 to get to the release in 2025. Now, last comment on this, I'm going to pass it back to you, Chris, is that when we think about this scale of what the AHA has put in together, led by volunteers to do all this work, it gives you the framework of this repeated cycle of this is such an engagement of the community, is what it comes down to. And when we think about other, like I've been involved in a lot of other evidence-based guidelines, airway, naloxone, a lot of different things. And this type of movement is so hard to come by. And I think that's one of the challenges that we're going to face in the future of dissemination and implementation when we think about how do we get these important concepts to stay in our consciousness so that we can continue taking care of people.
Yeah, that's phenomenal. And I mean, just looking at that timeline again, I still struck. I mean, 3+ years of a cycle where, yeah, you barely have a break from the last time, and you're already asking everybody to get back together and start reviewing the science again. And it's crazy. And in fact, it takes so long. I just want to highlight that you're having to re-review because, since we did this, it's been a year, and you're just getting it. It's such a Herculean task. The other thing that I just want to pull out of kind of your comments is I think about the American Heart Association as this machine that has developed and really chiseled a process to disseminate, to educate, to implement guidelines in a very robust way that certainly I think is a model for a lot of folks. And yet it's also, I also hear from you this vision of continual improvement. And the concept that you're developing those methods, you're rethinking about those methods, you're still kind of modifying the ship as you're floating in it, right? And I think that that's important for us to realize that even when there's a process that we think of as at this point so ingrained. I mean, we 2005, 2010 guidelines, big changes, and now we're at 2025. And so there's this process that is there, but it still requires all of us to consider what are the best ways to do that? How do we modify our methodology? How does timing play into that in terms of, when we can do that optimally, and just trying to kind of get that right. I think that there's a lot there. One of the items that we've discussed in our meetings before is regarding this concept of a full 5-year cycle where you're going through this enormous effort, just as we're describing. And then the challenge that the science keeps changing at such a pace, particularly with certain questions, where we end up essentially wishing or wanting there to be, a further update or a sooner update than that process might allow. And so, some of what the American Heart Association had engaged in is these focus updates versus the big 5-year updates. And I'd love to talk about AHA, and then we're going to spend a little time talking about, I think, where others can learn some lessons or think about how they would update their own guidelines. This is actually an element for me that comes back to when we wrote the National Prehospital Evidence-Based Guidelines Strategy that ultimately led to the Prehospital Guidelines Consortium being formed. We talked about this element of, could we promote that there be some cycle where we think that a guideline should be updated by? And let's talk a little bit about what your thoughts have been and your experience has been with these concept of focus updates, even within a 1 or 2 year span of time versus waiting for a longer period of time.
But I was actually the staff person that was able to work on the 2020 guidelines, where Ash was really integral in getting those out and then getting to then reinvent ourselves, if you will, for 2025. And I think, as Ash had mentioned, I think that's really important, right? Because not only is the science changing, but let's be honest, technology is changing as well too. And the way both technology is being used in the healthcare systems that we're working in, but also as we start thinking about evidence evaluation as well. And I would foresee even for 2030, is 2030 going to be the right timeline for the next guideline? I don't know yet. I think a little bit, I think we're kind of saying hypothetically that is the right time frame, but again, that's because we've done these 5-year cycles. And I think there's this really unique opportunity now that with technology to be able to maybe more rapidly cycle through that content, maybe less on the backs of our volunteers, and maybe being able to automate some of these other ideas as well too, or use AI, for example, for certain functions that are very administrative in many ways. But I think the big point I always kind of get back to is there enough science in which we can actually put out a recommendation change? Because again, there's a lot of effort that goes into translating this into the community. We know there's like the 17-year gap traditionally from guidelines being written to being implemented fully in the clinical arena. And so we don't want to just sort of send out recommendations every time and then people are lost in the shuffle wondering what's new, what's old, et cetera. So I think there's got to be a really concerted effort to make sure that there's enough that is changing that we can batch that in some way. And that was something actually that we heard a lot from our instructors. They don't necessarily want a 1-year cycle, because it's hard to keep up, right? It's hard to make sure that you're up to date on all of the changes and implementing those into the products that they're using to train others as well. So I think, the timing is important, the amount of data is important, and then also the burden in which it is to disseminate that information, I think needs to be considered, because again, there's a lot of overload, there's a lot of ways in which you can get that information, and we want to make sure that we're doing the critical things that we know matter for patient care.
And to piggyback on that, from the volunteer perspective, when we finished 2020, and even before, a little bit before 2020, we're thinking, hey, technology is so advanced that we could probably just do focused updates. Couldn't we just do focused updates and just kind of, keep giving little updates along the way as the science hits that level, and we'll be able to talk about just that important science? And it's amazing what the community responds to and what that feedback we got directly about the fact that, hey, you know what? Having that discussion at this 5-year cycle where we all get together and really argue about things, and you see everything placed in front of you, there's something to that characteristic of bringing everyone together and having that fight and having that argument in the community as well as in the scientific literature, all of it, right? And so I think it's one of those challenges that at the same time that we see innovation continuing when it comes to technology, we still have to think about the educator and the learner and how they are able to instill this knowledge into themselves, and what's the best way that we hit them. Because this is not like me, who I'm a resuscitation junkie. I'm going to read this stuff every day, versus the other individual who may not be so much, but they recognize this is important for their care. And that difference about the speed of science versus the ability of a learner, that's an area that I don't really have a great feel on quite yet. And I think there's more work that we need to do to understand that.
But I think that, if you look at the number of end users we would have to touch annually, right? We're in the tens of millions of people globally that are understanding, taking our courses, are reading our content, are able to access the information online from circulation. The number of end users that need to be able to both get the information and then integrate it into clinical practice is pretty overwhelming. And so to Ash's point, I think you have to make sure that you're doing it in a way in which it makes sense to the community, right? So I saw a comment about periodic updates and, is it every quarter? Is it every year? There's got to be probably this happy medium of information overload. Tell me what's most important. Tell me what to change, and then let's move on, because I've got 100 other things I'm trying to do at the same time.
And we do needs assessments. Last thought on this. Sorry, Chris. We do needs assessments. And that is a really important component about how we go about our cycles and how we think about focused updates. Is you really need to understand your population and ask the questions and say the feedback is, hey, everything you're doing is not what I want. You need to be open to hearing that.
Yeah, and we're following along in the chat here, and I think that there are great points about if there's an immediate thing that the science tells us we should really be doing, whether it's, how we're defibrillating somebody or back blows or, different things where we think, well, we really need to explore that evidence. And maybe it is, maybe 3 RCTs just dropped that tell us that there is really something that we should be promoting. Yeah, we're kind of stuck on that. Well, we just updated the guidelines. We'll talk about it in 4 years, is a challenge. On the flip side, we focused a lot on education here about the dissemination piece that I want to build on a little bit more in a bit. But on the education piece and how the educators themselves are saying, hey, this is it's a moving target. It's hard for me to have lesson plans and it takes time to get to all of our folks and all those challenges. But, I get reminded of some of the curveballs that happen over time where how quickly something can get updated has nothing to do with education or dissemination. And I think back about when the 30-2 compressions versus 15-2 compressions came out, and the realization that at the time, AEDs did not have a little USB thing you could just plug into and change the configuration. And, suddenly we have a new recommendation that essentially makes a lot of EMS agencies want or have to get new AEDs with new programming and not just change how folks are educated to perform something as basic and simple as CPR. But now we have, potentially a whole change in innovation for equipment. And that is just going to take time, no matter how quickly we want to move. Some elements of recommendations are going to require a whole lot of downstream things down at the EMS system level, some of which we might anticipate, and some of which, frankly, can be difficult to deal with. And so,
Chris, I just wanted to add too that we did do 4 focused updates in between the 2 cycles of 2020 and 2025. So when temperature control, when the studies came out of Europe saying that targeted temperature management maybe wasn't the right strategy all the time, we right away looked at that data and then released a focused update within a year. Delayed cord clamping for neonatal life support as well was another one where we had to sort of be responsive to the data changing. Now, again, that was still a year, right? It took us a while because we have to meet, we have to talk about it, we have to figure out what the recommendation level is going to be, and then we have to be able to put it on paper and then get it published. So there's still that lag time, right? Even when there's great science. And I think that isn't necessarily a bad thing, right? Because what if there was another RCT, or what if there was something else that came out in between that was important to think about? So I think, again, there has to be both the science and the timing that make it work. Just wanted to mention that too, is that we do have a process for it. It's not utilized obviously as much as the guideline revision cycle of 5 years, but there's got to be some really landmark studies that come out to have us do those focused updates.
Yeah, and I think, frankly, with this, without getting into the details of the most recent guideline update, that's what some of the conversations that have been happening in terms of, maybe there is an RCT that suggests that something would be reasonable, but is that enough science that we would tell everybody this is really what you should be doing? And are we at that spot where that level of a recommendation should be made, or are we, recognizing that's there and encouraging another RCT to be done to support it, and then finding the time period that we then say, okay, yes, that now the science is strong enough that we should all row together and with this in place, versus what I also see as being an issue when, maybe a recommendation is made because it seems like that's the way we should be doing something, and then the next 2 or 3 studies suggest maybe we need to backtrack. And that, that's its own challenge and part of the consequence of this timing issue.
And I just want to reflect on what you said there, Chris, because I think what you brought up is a real issue when we think about implications for EMS systems, right? I think the classic example is therapeutic hypothermia. And we really, all of us, I'm one of them. We put these into our systems. We thought this was good. We saw the original studies. We went ahead with it, right? Full force. And our recommendations supported it. We had everything in line to move forward with that. And in the end, we realized that the amount of saline sometimes that we're giving may have actually hurt people, right? And it's that reflection of the science that when you look back on that literature, and it's actually a great experience to do it, and sadly I've had to do it, is to look back and be like, you know what, this is where the science was when we made these decisions. And I think we've learned those lessons. And so sometimes people will say, okay, we're a little gun shy, but it's also we have to reflect on where our culture has gone with social media, podcasting, and jumping on these concepts. And if we put the two concepts together, we're a little more conservative with recognition of the potential impact and damage we can do to so many people, and at the same time being responsive to so much of the quick, I want to talk about something through the social media cycle, that we're in a rock and a hard place as evidence-based guideline individuals in general. And that's all of us in this 100-person call, is that we're kind of stuck in that middle space where we need to be responsible and find where that sweet spot is, but at the same time respond to the conceptual frameworks that are happening in EMS. And we've seen that as examples, right? We've seen examples in us in our literature right now, and we should call them out. DSD, heads up CPR, like, right? There's a lot of stuff which is new and exciting, which could really change dynamics, but it demands the data. And there are spaces that we need to have those discussions and make sure that we're doing the right thing for people.
Yeah. And, thinking about it as an EMS medical director, if I'm, planning out my next journal club with our paramedics, and we're having a conversation about the newest and latest, greatest thing, what goes through my mind certainly is, so here's an RCT, maybe it's the best RCT ever. It gives us an answer for that population. But at what point should we really implement something? I just want to reemphasize that point, that in this age of technology and information being much more readily available, not just to the medical directors and the researchers, but all the way to the clinicians, and having that increased involvement of EMTs and paramedics being knowledgeable about what science is coming out there, and hearing about these publications, reading them, being proactive about wanting to implement new science. It becomes a real challenge to try to decide, is now the right time to move forward with that? Do we wait for the guideline to be updated to provide the recommendation or not? And the other thing I would highlight here is, I actually increasingly thought of, guidelines as that opportunity to kind of highlight that now is the right time. And that's really, frankly, Ash, putting on you and others creating these guidelines, putting it on your shoulders to say, okay, now we have a bunch of smart people in a room, sat down with all of the literature. We have thoughtfully thought through that and compared it in a concrete, organized way. And now is the time that we should proceed with our recommendation or not. And I think that's a really good benefit to the rest of the community who doesn't maybe have the access to all of that information, at times might not have the skill set to analyze it in a way because it's just not what people do for a living, and that otherwise would not have the opportunity to look beyond that one paper to try to see, is this the time that we move forward? And so kudos to you and the hundreds of people involved in this world that help to try to do the best that we can to aggregate that and then figure out a path forward. Whether it not becomes fast enough in shifting with a recommendation, I think is a struggle that is going to continue to happen. And we'll, as we talked about, continuing to modify methods over time, I think this is going to be a continuously, moving ball. We're going to have to continue to calibrate when is it appropriate to do a focused update versus a periodic bigger update. And I can only imagine that this will continue to change.
One thought on what you're saying is, because I think looking in the room, because that's one of the things that I think a lot of people don't get, is looking into the room. And I did a podcast for the Rapid RN, which was great. It was a lot of fun. But we talked about the concept of what does that room look like? And how, when you make these recommendations, so much of the minority voice becomes really important. like hearing what people really have to say, which is that minority voice, which says, hey, this could have deleterious effects that you've never even thought of, right? And I was reading some of the chat where people are like, hey, 50% of the science ain't right, and we just don't know which side. And it's fun to think about it that way, because it really puts us and the work that we're doing to put together evidence-based guidelines in any area so critically important.
And I was just going to say, and by the way, Ash, I think you've officially, you're not just a resuscitation junkie, you're actually a guideline junkie also, too. The fact that you're like, this is so fun, 50% is wrong all the time. So I just want to put that out there, which is probably why you've done so many cycles, but thank you for that. I think the other thing, Chris, that you mentioned, too, is the speed in which practice sometimes changes is not necessarily always evidence-based, right? Sometimes it's social media and influencers who maybe pick up on a concept and say, hey, have you guys tried this yet? This is pretty awesome. And all of a sudden your residents, on shift or trying something different that may or may not necessarily be supported by the science. And so I think you also have to balance, as an organization, we have to make sure we're still relevant, right? And that there is still that integrity and that trust, and that we are doing the due diligence to make sure that what we are coming out with, as Ash said, is truly the thing that need to be changed, because there's so many implications. I'm reading the chat, 3 to 4 months to get it into my, EMS system before it's actually implemented. If the science is not there, we don't want you spinning your wheels in doing that. I think that's a really important thing to just kind of take into consideration. And social media, for example, like when we put out our mechanical CPR guidelines for recommendations this year in 2025, they went haywire. Right. And they went off saying like, oh, my gosh, everything's totally different. I can't believe that the AHA is changing their recommendations and no longer saying mechanical CPR is important. We actually have the same recommendations from 2020. They were sort of maybe interpreted differently by somebody online who then was able to have this sort of, social media influence to have this conversation. And we've actually had to now backtrack a lot to say, look, the guidelines haven't changed. Like if you need to use mechanical CPR because you've only got 2 people on a rig and you need to have the hands-free for somebody to drive, use it. Right. That's the same way it's been since 2020. So I think there's that balance between not only having to make sure that the messaging gets out, but the right messaging comes out from the organization in which we are trying to make sure that people understand exactly what we're trying to say.
Yeah, and there's also that challenge, just the basic challenge of science versus practice and science versus experience. And, there are also comments that we're seeing here from folks online about, maybe the EMS personnel at my agency just aren't in tune with the science and they don't care so much about this paper, that paper. We have to have that, balanced standpoint to say, yes, we want to proactively change practice. We want to improve, or maybe how we've always done it is the way we should do it. All of that has to get balanced in there. But it's important to think about at what point is it worth actually trying to get everybody to change their practice. And I think that's actually what the big labor is, and where the challenge becomes to try to provide a recommendation of this impact is for that level of recommendation to move forward. It has to be based on a recent concrete bit of information there.
And I think we also have to keep in mind guidelines are guidelines, right? We're not writing protocols. We are giving you the bare minimum, right, in which we think you need to be able to take care of a patient well, who has using evidence-based clinical practices, right? And so I think that's always something that we always have to remind people is that we're not writing a protocol for you. We are giving you the information. We are giving you a way in which to organize it. We are hopefully getting everyone on the same page in terms of what the ordering of sequencing of these activities are. But ultimately, it's up to you as an EMS medical director to take that information and implement it into your clinical practice.
For sure. And kind of moving on to talk a little about dissemination. This is, we've talked about how timing really plays into how we get guidelines out there and certainly how we educate about them, implement them. We even talked about some hardware things that might need to get modified to truly be able to implement some things. But one of the items we've been talking about at the PGC is related to dissemination and guidelines. And so I want to talk about and use lessons learned by the AHA, but I want us to branch out and talk about other guidelines. What can other folks learn from to try to promote the dissemination of other guidelines out there so that they actually can get implemented and used? As we do our systematic reviews of pre-hospital guidelines every 2 years now, we have the privilege of identifying quite a number of published guidelines that are very robust, they're high quality, whether related to trauma, TBI, pediatric care, whatever the subject is. we have a number of very useful guidelines. And I fear that they get published in a journal and many people don't know that they're there. And they don't actually get implemented in many EMS systems. And in fact, when I go around and say, hey, did you know that there is a phenomenal guideline on pediatric traumatic brain injury management? Did you know that that's out there? And have you thought about how that gets implemented in your protocols? And maybe many people haven't. And so, what I want to talk a little about kind of lessons learned or ways that folks could try to promote dissemination of guidelines. And you've talked a little about some of the many connections that you've had with other entities and other organizations, with the educators, with other with aligned providers, things like that. Do you have any thoughts on lessons learned or what other things people should be mindful of as they are developing a new guideline?
Start with one, which is choose your partners, right? I think that's really important. And so we're very fortunate. In 2025, we chose to jointly release pediatric guidelines with the American Academy of Pediatrics. That is the core audience, right, for many of those guidelines. So again, we're very fortunate in that we have this amazing partner that already has that audience already part of their organization. So I think that's an important piece of it. We wrote our first aid guidelines with the American Red Cross. Right. We wanted to make sure that our content was the same so that when you took a first aid course, you were getting the same content, right, that you would be getting from our course as well. So I think that's a big part of it. We also have such collaborations with the American College of OB-GYN, American College of Surgeons. Ash and I are working on a project with them together. I think it's really, as you're writing the guideline, one of the most important things is, as you're writing it, is to think about who are the people that need to be at the table. Maybe they have a voice in terms of being able to help you with the recommendations, or maybe they just have a voice in terms of dissemination as endorsing the guideline and helping you promote it to a certain audience. And so we had those discussions even in 20 about who we thought those important partners would be. So I think just keeping that in mind as you're writing the guideline, or even before you start the guideline, who needs to be at the table to make sure that these recommendations are actually going to be implemented in clinical practice.
Yeah, go ahead, Ash.
Oh, no, I was just reflecting a little bit because I think when we think about dissemination and we think about how we develop these guidelines, the partnerships are critical for a number of different layers, right? So I was reflecting a little bit on what's in our chat about how we message these things out. And frankly, it's really funny. As volunteers, you're in the trenches, you're doing all this work, you're putting things together, and you put something together and you're like, wait a second, that's not what I meant. And it's so funny because no matter how well-meaning you are to try for hours and hours to find the right words, it still comes off as a different way. And your partners are there to help support you to actually understand what you're saying, the implications. But even after all that, you will still drop the ball sometimes, because when all is said and done, you're vested. You're vested in this concept. And when we think about the larger mission of what we're trying to do, when we think about these guidelines, we need to get that core message. Do CPR, like do the key things, call 911, push hard and fast, right? The core message has to be really transparent. And so many times we get lost in the minutia, but I think one of the big things that they were talking in the thing is getting educators engaged in how to disseminate this. And as we think about our partners, one of the great things that I've liked about our partnerships are so many educators are involved all the way down to the training networks. And that's really critical because they reflect back on us so much about what we're doing, how we're doing it. And so I want to reflect on what was said in the chat, that getting educators involved as part of your dissemination plan, so critical. And that is one of the things that I feel like we do pretty well at times.
Yeah, and I just want to emphasize the concept of when writing a guideline, or position statements are another way that professional societies provide recommendations, and particularly even when there isn't that much science to really be able to write what we would otherwise term as a robust guideline. These are the ability of our professional associations to collaborate and partner with each other to make sure that as we develop a recommendation that we're considering the perspectives of other specialists that are going to look at things from a different viewpoint. But simply, as Camilla said, just having the dissemination pathway there in terms of, is it that audience that you're trying to reach? If somebody is already representing that group, then you've got to grab onto them. I really, if you think about what has happened in the past decade or so, I think that all of our professional organizations are much better at collaborating with each other and being thoughtful about how to engage. I think we still have some room to improve on that, all collectively as a community. One of the things that I know that we've highlighted, in position statements that I've been involved in, is making sure that we're engaging each other in the process as early as possible. It's much better if you're an organization and you're going to be asked to sign on a position statement at some point. Well, let's engage each other at the beginning of the process so that you can have those viewpoints from the start. So as we're evaluating the science or as we're doing things, we're at the table at the, when it matters. And that makes it much, much better. At the end, we can support each other. We can do that co-signing of position statements. We can co-publish in each of our journals. It is happening. Now, which I did notice that 2025, there's a bunch of co-publishing happening in those different, pediatrics or circulation versus others. And that's important, again, to try to get to the right audiences.
Just a thought. I think I'm thinking about the future more and more about how this works. So after this guideline process, I've given 24 talks after this guideline process. It's been insane and I've loved it. And some of the best talks I've enjoyed is with podcasting where we actually have the argument. And more, I think, as I think about the future, I think part of our dissemination plans needs to include this type of social media engagement, right? And we don't talk about what's the right way to do it because I don't know what the right way to do it is. I don't know. I actually am not sure, right? And so like a lot of times I've been telling a lot of people, I'm like, hey, I'll come and talk about anything you want me to talk about, especially around this stuff. But I think that's one of the things that we're going to need to think about in the future, particularly for EMS. When we think about EMS engagement, a lot of clinicians, educators, and others will engage on social media through podcasts, through all those different pieces. It's not just the writing anymore. And if you guys are starting to think about different guidelines that you want to put together, we need to start thinking about how that might look and how you might engage that side such that we can enhance dissemination in a different mechanism to help get the word out.
Yeah.
I'll say, even though I'm an ER doc, I've learned a lot in my 11 years at the Heart Association. A MarComms plan, right, might be that marketing communication plan might be the most important thing we do. It's not actually the guidelines, sorry, Ash, but it's the way in which we actually sit down with our marketing and communications colleagues and say, okay, what are the channels that we think are important? Who first identify the end users that we want to get this information to, then work backwards to say who has these channels already so that we're not trying to recreate the wheel. And then how do we engage them? And in what way do we engage them? And as you just mentioned, Chris, is it right at the very beginning of writing the guideline, or is it at the end when we say, hey, do you guys mind endorsing this? Because we know this is an audience that might be important, for us to get the information out to. So again, I know not everyone has an organization that's working behind the scenes, but just even sitting down and just thinking about that as you're writing the guideline, which is hard to do, that's going to be really, really important. And just putting it out there, we don't know what social media is going to look like in 5 years.
Yeah, and this is where we're having to. Yeah, we're having to write this as we go, and we're gonna have to modify it, and it's not going to be the same. And it's not going to be the same answer in 5 years as it is right now, potentially. But I think that we need to be thoughtful about it. We need to think about it proactively and include it. The PGC published some recommendations for writing of high quality guidelines, and one of the elements that we included was to provide some content within a guideline that addresses the implementation of the guideline. And it's not prescriptive. It isn't that we're saying there's something specific to include there. Is it elements of how the guideline should be disseminated? Is there a performance parameter that could be identified with it? Is it that we want to, just monitor how specific recommendations are implemented? But this goes along with it of coming up with that plan, as you said, marketing implementation plan. How is it that those recommendations are going to get out there to the layperson or the line clinician? We're also hearing here a lot about this challenge that we have for dissemination when the end user doesn't have access to the publication. And that is a real problem for many other guidelines where they're not available as open access. And I think it's twofold. One, that somebody physically cannot access that publication without paying for it or just, whatnot. And then even sometimes when things are open access, a challenge with dissemination is that people don't know how to access it. They don't know where they can get to it. And so, I think the AHA as an example does so many different things to make people aware of where it is, available on website, open access publications, all of those types of things where, as a minimum, for example, with another entity could do is try to assure that if you're going to go through the process, particularly through a grant-funded effort to create a guideline, you should pre-plan that would be available to the general public. We can have mixed feelings about open access fees and partnering with journals and things like that. But I think we at least need to have the conversation early on and be mindful of if this group is going to go through the effort to create this robust guideline, then how can I ensure that the true end user can access it downstream? And that needs to be part of the conversation. And if there is a grant funding for it, then yes, budget some amount of money so that can be made available to everybody downstream.
And Chris, I love what you just said there, because that's almost like the minimal. And that's probably where you start. I do want to reflect on one of the things we're just saying in the chat is that, how do we disseminate to EMS in general, right? What's the strategies you'd use? And that's one of the really challenging things, going back to what Camilla said about a MARCOM plan. From 5 years ago in 2020 to where we are in 2025 has dramatically changed about how you disseminate to EMS. And not only that, the people who are involved in podcasting or social media have changed, have evolved. Like every step of the way, we are having changes. And it's like the baseline is just to get the paper out. And as a volunteer and a researcher, a lot of times I'm not the best person to be actually the spokesman because I just don't know all the people to talk to as part of the larger plan. And if you're thinking about something like an NEMSP scientific statement or a position statement, it's like you start with the basics, and there's so many things that we don't know right now about how to get it to each individual's hands. So that's a continuing conversation that we need to start talking about. What is the strategy there? Because we don't have one yet. Camilla, go ahead.
I was just actually going to refer, I think there's a great content here too about sort of the rural-urban divide, if you will, and then also kind of, which I think ties back into access, right? And, if you've got a volunteer firefighter who's, is doing 100 other things for their day job, is it really, are they really going to sit down with a 400-page circulation publication, even if it's free? No, so if you think about kind of the strategies that we've at least tried to adopt, we put together a highlights document, for example, which is sort of here's the, here freely available, and we've disseminated that widely, freely available to anybody who wants it. It's like 30 pages or less, and you can look at your topic, right, and say, here's what's changed, here's what's important, here's what I need to know, because I don't probably need to know about neonatal because I'll never, worry about that, for example. So that's one thing. We have a podcast, a digital digest that we also have put together. So as we were writing the chapters, we actually had our chairs do a podcast, a 10-minute podcast that highlights the major changes in the content so that was ready to be released on the day of. We worked with our entities like I said, with AAP and others to say, hey, on the day of launch, can you just help us promote this? And then what is that plan continuously, right? Because October 22nd was fabulous, but there's a lot more time and effort that needs to go on after that. And then even with our co-launch with the European Resuscitation Council, we were meeting a year back trying to make sure that our content was at least somewhat aligned, and then choosing to release that on October 22nd with ERC and ILCOR. There was a reason for that, because that was really kind of putting that one, for that day, the global community for resuscitation came together and released a whole bunch of science. No matter where you are, if you're a rural area, if you're a low middle income country, we have put out some guidance, and we've kind of told you what's similar and what's different, which, by the way, most of it was similar, FYI. I think those are just kind of ways in which you have to sort of think about that dissemination plan. So there's the big splash, but then also, what are we doing after that? And then how are we going to make sure that the person who has a day job gets the information when they need it? I think that's really like very critical to be thinking of.
Yeah, for sure. I think about some of these lessons learned. What I'm hearing is it's got to be a multimodal strategy. You have to think about, as Ash mentioned, the bare minimum, the document has to be accessible. But again, you're right, 200-page publication is not something that your volunteer firefighter is going to sit down and read. I know that it is actually the case for some individuals, but we can't expect that that's the way that they're going to receive that information best. And we really need to think about multimodal strategies of dissemination, multimodal strategies of implementation to try to think about this. And this, at the end of the day, it is again about partnership with entities and organizations. They're going to be folks, at a statewide or regional or even local level that will be best at understanding how to receive that information and then disseminate it to their entities and how that is going to work out better. So, if we have the opportunity through the guideline development process to develop some toolkits, to be thoughtful about, here are some examples of the ways that you may want to disseminate that across your individuals. Here are some resources that you can use for implementation in your local level. This one may work for you. Instead, maybe this one may work for you in giving those, back to the concept of folks aren't even reading anymore. They're just listening to podcasts and other things. This will end up on YouTube. Hopefully there are others that will engage outside today's conversation. And what are the ways that we can make those things available?
And Chris, just to reflect on what you said, there is some great work being done right now, understanding the science of dissemination in EMS. Jen Fish is doing some amazing work in this space to really start identifying what's the best approach. And I think you're right. I think there's going to be different approaches for urban, suburban, rural, like there's different approaches and different methods and for age groups too. And I think we're at the beginning of that science. And so the more we can promote our dissemination scientists to help them get supported about how they figure out what we do to make this happen, that's going to be really important for the next 5 to 10 years because it keeps moving along.
I think you have to be nimble. I mean, most people probably don't think of large organizations as being nimble, but in order to stay relevant, you have to be nimble to some degree, right? And you have to be able to say, like, even though the strategy worked for 2020, it may not work at all for 2025, and it may not work at all for 2030, right? So I think, again, just kind of keeping that ear to the ground, really listening to your end users. So I appreciate the amazing amount of comments that are coming through the chat because you guys are the folks that we are trying to reach. And so any ideas that you have, please, I welcome those conversations that should continue way after this discussion, hopefully. So please feel free to email me at any time. We want this feedback. We want to know what the channels are that you use personally to get the information out so that we can work with you at the local level to get that information out. That's what's most important to us.
That's great. So we're coming up at the top of our hour. I feel that this has been a phenomenal conversation, and I hope that it has helped folks to kind of wrap their head around the concepts of dissemination and implementation when the backdrop of these, huge guideline set that just got, recently dropped by the AHA, and thinking about how we might take some of those lessons learned and implement them outside of that group into other guidelines that get developed, because we're actually publishing in the realm of 30 to 40 pre-hospital guidelines a year across many professional associations. And I think that they're great future opportunities for us to continue learning from each other and do think through how should my guideline be disseminated and implemented so that it is actually used and useful as I sit down to develop it. So in the Q&A, we've actually done our best to follow the chat along. We've commented on it and things, but we want to give an opportunity to contact and get further information for the group in the future. We have American Heart Association's website. You can drop that into your search bar and look right at the American Heart Association's guidelines. Prehospitalguidelines.org is where the PGC is. Prehospital Guidelines Consortium performs systematic reviews of prehospital guidelines every 2 years, currently doing the 2026 update. We have a repository of prehospital guidelines that are out there and certainly is a resource for other things. And then I want to really thank the University of Florida for helping to co-sponsor this and helping to set this up for us. and Jennifer Brailsford for being able to help host this, along with Jen Fish, who's the chair of our Dissemination Implementation Committee. As got highlighted, I really want to appreciate our partners. And thank you a lot, Ash and Camilla, for joining us today. This was a wonderful conversation.
Thanks, guys. Appreciate it.
Thank you, guys.